She is highly skilled in safe disease investigations and outbreak reporting. She's currently serves as the head of infectious disease unit in the antimicrobial stewardship program at the Network Hospital in Ministry of Health. Today, she is going to talk to us about the Cryptosporidiosis. And I'm sure that it is going to be a very interesting topic.
Assalamu alaikum. Good morning, everyone. Thank you for this nice introduction, and thank you, Menace Group, for this kind of invitations. My topic today is about the cryptosporidiosis, the waterborne Menace, and in Arabic it's يعني طفيليات خفيات الأبواب, we call it. Okay, so I have no disclosures. This is my objectives. I will be talking about the etiology and pathophysiology of cryptosporidiosis, clinical representations and diagnosis tests, and treatment and infections. So what's cryptosporidiosis? Cryptosporidiosis is intracellular protozoa that infect the brush border of the small intestine caused by Cryptosporidium. It can cause enteric pathogen, diarrhea, and watery diarrhea. It can be chronic, especially in immunocompromised patients. It has two cycles, sexual and asexual cycle. It all happens inside one host, human being. So that's why the human considered to be a definitive host. There is no intermediate host. So thick wall or oocyst in the stool considered to be infectious stage and diagnostic stage as well. Distribution is worldwide distribution, all over the world. It's a small coccidian parasite. Usually it's very small, tiny, 3 to 5 microdiameters. It's high transmissible. It's environmental parasite, can be seen in the soil, waters, and contaminated surfaces. A human, as I mentioned, considered to be diagnostic and infectious stage. It was first discovered in 1907 by Edward Kaiser in the stomach of mice, and it was first recognized as a human pathogen in 1976. The attention was increased about this parasite in 1982. It was associated with AIDS population. So little we know about cryptosporidiosis. The unique thing about the cryptosporidiosis is intracellular and extracytoplasmic, and that can cause enteric diarrhea and illness. And this is unique about it because that can make cryptosporidiosis difficult to diagnose and difficult to eradicate because it's intracellular. It's usually circulated in immunocompetent patients, but fatal and deadly in children and immunocompromised patients. They have extraintestinal manifestations, like we can see it in biliary and respiratory tract, usually in immunocompromised patients with HIV with low CD4. So this is a scheme. As you can see, Cryptosporidium is attached to the invade the brush border of the intestinal with this red arrow. It's intracellular but extracytoplasmic, and you can see this is biopsy of columnar epithelium of the small intestine, and you can see this is around the red spot on top. You may feel that it's extracellular, but in the electron microscope you found it's intracellular but extracytoplasmic. So this is the life cycle of Cryptosporidium. As I mentioned, human considered definitive host. So the complete cycle happens, sexual and asexual cycle inside the human being. So when microgamete here, I don't have a pointer. So here you have microgamete, fertilized macrogamete, and produce zygotes that produce related oocyst. So this oocyst existed by human, then excreted the stool. So this is what we infective stage. We consider infective stage and diagnostic stage as well. We have two types of oocyst. We have thick wall oocyst and thin wall oocyst. Thin wall oocyst is responsible for thin wall oocyst because it's thin wall, so it can be first inside the intestine and can release parasite that can cause also internal infections. While thick wall oocyst, it is usually responsible of secreted in the stool, and this is responsible for external autoinfection. So external autoinfection can be reinfected with the same host, or transmitted infection to another host. So what about pathogenesis of Cryptosporidium? As a parasitic, Cryptosporidium is not releasing any toxin. Direct damage through mechanical damage and invasion and replications of this inside the small intestine, and by releasing cytokines and activating macrophage and causing more villus atrophy and crypt hyperplasia. And that leads to nutrient malabsorption and diarrhea. So this is a pictures, you can see A, it's healthy intestine, while B, you can see there is villus atrophy, cryptitis, and crypt hyperplasia. That leads to the malabsorptions. So what about extraintestinal manifestations of Cryptosporidiosis? As I mentioned, it can affect pancreas, gallbladders, cause acute cholecystitis, pancreatitis. It can involve the lung, causing pneumonia, chronic cough, and possibly infected conjunctiva as well. Incubation period usually 7 days, from 2 to 10 days. In immunocompetent, usually they have limited course of diarrhea for 2 weeks, associated with abdominal pain, anorexia, fever, weight loss. While in immunocompromised patients, they will have more severe diarrhea, especially with low CD4 and HIV patients. And diarrhea can be persistent more than 2 weeks, associated with dehydration, abdominal pain, anorexia, and malabsorption and weight loss. So we know that Cryptosporidium have many species and can infect mammals, birds, and animals as well as human. But the most common type of Cryptosporidium is Menace, that exclusively infects the human, while Cryptosporidium barbum can reinfect human and animals as well at the same time. So this is 13 reported species isolated from a human being. As you can see, 98% are Cryptosporidium hominis and Cryptosporidium barbum. So what's the mode of transmissions usually? By fecal-oral transmissions through infected oocysts. It can be transmitted through the waterborne, which is the most common, through the swimming pool, the recreation centers, or foodborne transmissions with the infected food, or animal-to-human transmissions through the farm, or human-to-human transmissions. We can see it in children mainly with daycare centers, or household contact, or healthcare workers. So let's talk about the epidemiology of Cryptosporidiosis. It's involve all the continents, all 6 continents. It's involve all age group, but more common in infants and children. It's highly contagious. So sometimes you need only less than 10 oocytes to get the infection, especially in immunocompromised patients. While in a healthy adult infected with the Cryptosporidium barbum, they need at least 132 oocysts. You have to know that Cryptosporidium is resistant to chlorine and standard water sanitations, and it should be by boiling waters. Okay, it is susceptible to drying and ultraviolet washing sunlight as well. The highest incidents are often reported in low and middle income countries where the sanitations is poor to the clean waters. The annual incidents depend on seasonal variations, environmental conditions, and public health interventions. In the United States alone, approximately 823,000 cases of Cryptosporidiosis are reported annually, with about 9.9 prevalence attributed to the international levels. What about in Saudi Arabia? Saudi Arabia, there is varies between the prevalence cases in Saudi Arabia that depend on the regional immune status of populations and availability of the test modality, because we have many methods to test Cryptosporidiums. But there is sporadic of cases. It's been seen as a report cases from Taif reported that prevalence rate about 10% among the area patients. And this is changed depend on the method that used for diagnosis. For example, it was 9.4, 10%, 11% by macroscopic or immunofluorescence or PCR respectively. It's more common in children than others. And it was higher incidence in Taif compared to other areas, Saudi Arabia, like Eastern province, like Khobar and Dammam. Another study in Riyadh, in immunocompromised patients, they show that higher incidence of Cryptosporidiosis. It's around 60 to 70% reported in immunocompromised patients. In Jeddah, they found by screening, they have 32 patients asymptomatic and symptomatic, I mean, and 4.7 asymptomatic children found to be positive, excreting thick oocysts in the stool. In the Eastern Province, which include cities like Dammam and Khobar, they have found the reported prevalence rate is very low. It's around 1% in children. What about GCC? GCC country, they found that Saudi Arabia have higher burden of reported cases compared to other GCC countries, and that could be related to importation of food from high-risk countries or presence of immigrant workers that can carry the infections, and the challenging related to the water quality supply. So how to diagnose usually cryptosporidiosis? Usually the cheapest one is to do microscopic analysis of stool cultures by using modified acid fast stain or fluorescent stain. It's a cheap, rapid, but it's low sensitive, usually less than 30%. Because you have sometimes intermittent parasitic shedding, so you have to repeat the test or you have to combine it with other modality. So we can use either microscopic identification by modified Zelnitzer stain or fluorescent stains or ELISA tests, which have more sensitive and specific. But again, ELISA can be false positive in cases if you have past infections, and can be early negative, can be false negative if you have low parasitemia as well. PCR is promising, but you have to differentiate if it's colonizing parasite or not. So we have to know that Cryptosporidium is usually underdiagnosed, because if you think about it, you have to talk to microbiology lab and ask them to send diagnosis for this. It's not isolated in traditional culture, so we have to have high suspicion in these cases. And false negative can be found because of low parasitemia or asymptomatic carriers or because of early symptoms. So if you have any case, you have to direct communicate with your microbiology or parasitology. It is crucial to diagnose the patients, and they can guide you if they have another alternative test, or you can repeat a test in your hospitals. So what's about the treatment? There is no effect therapy or chemoprophylaxis for cryptosporidiosis. Supportive care is a gold standard for self-limited cases. FDA approved nitazoxanide as a therapy of an immunocompetent patient, but there is no clear guidelines for immunocompromised patients. The efficacy usually 77 to 80%. Paromycin has been encouraging results. For individuals with AIDS, so we used to give them ART, can reduce oocyst excretion and decrease diarrhea as well. If you have patient immunocompromised solid organ transplant, you can reduce immunosuppression medication if possible, and sometimes they recommend and suggest to give nitazoxanide for 2 weeks if the patient is not improving. For HIV patients, as I mentioned, if he is not improved in ART, you can add nitazoxanide therapy. And as I mentioned, it's difficult to treat because it's usually intracellular and difficult to culture and difficult to do drug therapy and testing for these organisms. If you have severe refractory diarrhea in immunocompromised patients not improved in the nitazoxanide, you can combine with azithromycin for these cases. So what's the impact of the Cryptosporidium disease usually? You know that patient, he had infections, they have enteropathy, they have persistent diarrhea, and intractable diarrhea leads to dehydration and death. And they have long-term consequences like chronic fatigue, cognitive impairment, and because of the long-term side effects, especially in children and immunocompromised patients. According to the WHO, diarrhea disease are second child killers, especially in young children, and it was considered of top 10 child killers infection disease usually. So infection prevention control is very crucial. Currently there is no vaccine for this Cryptosporidium. As long as more water transmissions, it's very important to emphasize on proper hygiene. Boiling and filtering waters is very prior to consumptions, and chlorination is not effective to kill the oocyst. Travelers can reduce their risk of cryptosporidiosis by careful adhering to the food and water precautions. An individual who had the infected with cryptosporidiosis after they complete the therapy, they shouldn't go back to swimming pool 2 weeks, because they have intermittent shedding of this parasite. So in conclusion, Cryptosporidiosis remains a global health emergency, especially in children and severely immunocompromised patients. It's a pathogen most frequently associated with foodborne outbreak and enteric infections. No antiprotozoal agent or vaccine effective available till now. We have to implement an education and prevention program to control the spread of this pathogen. Thank you.
Thank you, Dr. Jamana. Now with the move to the second speaker from Mecca, Dr. Suad al-Mudari. Dr. Suad, she's a consultant in infectious disease and infection control specialist for over 17 years of experience. She's the head of antimicrobial storage program and the deputy of the infectious disease fellowship program and the deputy of infection control unit in King Abdullah Medical City and Specialist Hospital. Dr. Saad, she holds the Bachelor of Medicine and Surgery from King Abdullah University. She granted the Arab Board of Internal Medicine residency. She acquired the Saudi Fellowship for Infectious Disease, then followed by an Infection Control Fellowship from McMaster University in Canada. Dr. Saad is known academic collaborator, and she is also a researcher, and her name appeared in numerous publications.
Good morning, everyone, and it's a pleasure to be here in Al-Ahsa every year. I feel it's a trip of knowledge, entertainment, so I could say this as shampoo and balsam for mind and heart, and I would say it's a time to catch with everyone. And I would like to thank the scientific committee for every interesting topic. And just an intro for my presentation, I was thinking, why Giardia and why water? So I would just share my insight about this. Giardia, because it's the most common, let's say, parasites with variety of clinical presentation, which is definitely difficult to detect, difficult to diagnose. And why water? I was just having a lot of thinking and insight. Why water, if we believe in the map that we see that 70% of this planet is water? And again, if I said, if we believe in the map that we see, and I heard an insight from Dr. Mohammed Sha'rawi that it has two things. It has a knowledge background and religious background. When Allah subhanahu wa ta'ala said, وَجَعَلْنَا مِنَ الْمَاءِ كُلَّ شَيْءٍ حَيٍّ. So we had what we said, living things that live on water, like us as a human being, and water that has someone living in it. And there is a lot of things, gases, nitrogen. So definitely, if we knew by science that 70% would be enough to be consumed by the 30% that it was there, I think it was created in a very creative way and wisdom of God. So I just said maybe I could share with you this insight. So I will try to discuss with you today few epidemiology of giardiasis in Saudi Arabia, along with insights from global epidemiology, understanding the life cycle, and I will try to answer few why questions in the life cycle of giardia, clinical presentation, treatment option, and strategies for prevention. I found few publications about giardia in Saudi Arabia, and it was interesting because this was my first question when I had this title, was asked from the scientific committee to be presented. So do we really have giardia in Saudi Arabia? So I found this publication that was published in 1983, and it was a publication that depended on a collection of stool samples over 1 year from January to December 1980. There was a collection of stool samples, almost 53,000 plus, and they found, and it was in many areas in Saudi Arabia, northern, southern, eastern, and central region of the kingdom. And it was examined under microscope. Then there was around 5,271 stool were positive for giardia. Yeah, and this was, I could say, how would I say, wow. Yeah, this is definitely a huge number in 1980. And the prevalence was higher in male, 64% than female, and mostly the age group as those of children of 55 to 15 years old children. Okay, so moving forward among history, do we have a change from that time until today? Let's just dive through whatever statistic and studies was done in our country. 1986, a study was done in Riyadh to admit how much we have Giardia in Riyadh, and it was almost, I wouldn't say half of that previous studies to samples, 23,000 plus, and it was only collected from 3 medical centers in Riyadh, and the prevalence was equal to the prevalence of the previous study. So you could imagine that only half of the sample size, and they have almost have 6.3 Giardia lambia was the commonest parasite found in the age group of 15 years, and it was more in male as the previous study was shown. Another study, let's say on the 2000s era, and it was studying the prevalence of crypto and Giardia in Mecca city and Jeddah, and always, let's say most of those waterborne disease area of study is in Mecca, and definitely everyone would know why, because of the mass gathering, Hajj, and all those things that we, let's say a lot of effort was done to have safe mass gathering during Hajj and Umrah. So, this study was speaking about Cryptosporidium as well as Giardia lambia and water sampling from Jeddah and Mecca, and it was examined. They take different samples from different places in Jeddah and Mecca, from schools, from houses, from mosques. Then they tested for the presence of Giardia as well as Cryptosporidium. So we could see that the positive sample for Cryptosporidium is more in the school and house and mosque. And I think Dr. Jumana before me, she was mentioning that it's difficult to eradicate with chlorine. I was just thinking this is maybe a cause for that. Let's say Giardia, and I highlighted with yellow highlighted marker, that they found during their study 1 case in Jeddah and 2 cases in Mecca. When they used the stain, they found 3 cases from total of 124 samples in tap water, and this was Giardia. If we look to Mecca statistic, again in tap water, Giardia was 2 cases, and in the chart on the right side, they found Giardia in imbibed water 3 cases. Again, this is what highlighted that tap water is more positive for the Giardia in comparison to others, and it was more commonly to be stained with quinine stain. Another references that I find it, I wasn't able to find the publication, but they were mentioning that the Giardia prevalence among food handlers in Jeddah and Mecca were found to be 4.6 and 1.9 respectively. So, since I was preparing this presentation, I started to think about the water that I drink, to be honest with you. Then I prefer to drink juice, and you may see that I carry juice. I don't have water in my hands. Okay, so this would just indicate that risk of, let's say, occupation had impact on risk of infectious disease, let's say, or impact on having some of the infections. Another study that was finally, I find it, speaking about Giardia and amoebiasis, among patients that were suspected who was coming to the hospital with diarrhea, and it was published 2023 in Mecca from Armed Forces Hospital. They studied 922 patients who came with GI manifestation, as in diarrhea, as an inpatient and outpatients, and they found that the commonest diagnosis was amoebiasis, and the Giardia lambia was almost 0.3% of those patients, and its commonest was in Indian, followed by Saudi patients, and the age group was the similar of the previous studies. So I could say from this that the prevalence of disease is influenced by several factors like social, economic, and climate plus environmental changes. This is our pathogen that we speak about today, and I want you just to have a look with those 4 eyes organism and 2 eyes. Okay, I wouldn't say I would ask to take a selfie with it, but this is this pathogen, and I will try to answer a few questions, but after the life cycle. So Giardia lamblia life cycle or Giardia duodenals. Definitely the mode of transmission is hand to mouth or fecal-oral or contaminated food and water. They ingest the cyst, it goes through the stomach, then it will be in a stage of excistation and incestation, then it goes to the small bowel, and trophozoites will be motile, investing themselves in the small bowel and causing the disease. Then again, few maturations of those cysts, those trophozoites that ended by another cyst, then it will be excreted and just going again in the environment. But the question is, why is the cyst? Why we had the cyst as the infectious, let's say, pathogen in most of protozoa? I was just thinking about that. Then I do understand that the cyst is always environmentally stable. It doesn't be affected by the environment, and it has definitely an outer layer that would just help it to be living for a long time. You can just look to this protozoa, how it's hiding themselves by 2 layers, and it's thick layer, filamentous. It has this N-acetyl glucosamine that would really be in a major sugar. But if this pathogen is environmentally stable and it's strong, it doesn't need to it needs energy to survive. Even though this, I could say that this organism is on diet. So it just consumes 10 to 20% from a metabolic rate. So this is why it lived for a long time in the environments. This, let's say, fascinating word of excistation and incestation. I just got this slides from CDC speaking about the life cycle and how this incestation and excistation. Then I find it so interesting. Before that, I would just say that the incubation period is 1 to 14 days, average is 7 days, and usually lasts 1 to 3 weeks. Infection period, even if it is asymptomatic, it may be months as long as protozoa present in the stool. The cyst goes through the stomach, and with the change of pH between the stomach and bile, excistation will occur. So pH matters. So what we are doing with PPI and medications. So in the literatures, when I said pHs matter, so proton pump inhibitors, it provide more risk to have a giardia for patients because it changes the pH. Trophozoa multiply in the small intestine, and incestation with cholesterol and bile salt so happens at that place. And this is our friends in this presentation, and you could see that kind of flagellae that it will just help adhering and moving and invading the small intestine. Clinical pictures. So when it is, I think this is all applied in ID. When it is endemic, it's subclinical. It's presented unusual, it's not easy to detect, it's not easy to diagnose. So I think it's the same rule applied, and it has subacute onset of diarrhea, 1 to 2 weeks after exposure, with consistency of loose, greasy stool and flatulence, abdominal pain, and when it's prolonged diarrhea, it would lead to weight loss. Fever and other systemic manifestation is uncommon in this pathogen, and definitely giardia in children, it would lead to malnutrition and growth stomach. Risk factors for having the infection. I think you could just have an idea that children is definitely are more at risk. And I said in the previous slides that workers who work as food handlers maybe, or who work in sewage, they are at more risk to have this infection, plus high risk attitudes, and they report in some cases study and in some publication that sexual, let's say oral sex and anal sex is a risk factor for Giardia lamblia. I found in some studies that they mentioned that deficiency in some micronutrients like vitamin A and zinc is protective. And I think this would be correlated to the invasion of the pathogen in the small intestine. Diagnosis. Golden standard diagnosis is microscopy of fecal samples. If we could able to see that, but always microscopy is challenging because it's need an expertise. And how many expertise in parasitology we have in non-tropical area. Also it's difficult. You can see in this, let's say, table that there is a lot of media to culture. Despite that, it's difficult to have a culture. And microscopic examination, it's need a fresh sample to see the cyst. Despite that, again, I would say that it's difficult to diagnose. PCR, at the era of PCR with Giardia, there's a lot of, let's say, commercials and marketing about PCR for ELISA. Is it sensitive and specific as it is for a microscopic exam? But I think the limitation of PCR is when it is asymptomatic. I don't need to diagnose someone who's asymptomatic and had no clinical picture that indicate treatments. Other diagnostic modality is doing intestinal biopsy to reveal presence of trophozoites in the intestine. And again, this is would need an expertise to have it, plus the last things, which is serum antibody, and it is only used for researchers. Moving to the treatment. Challenging, as I said, it's difficult to treat in endemic countries, since the patients would be asymptomatic and having reinfection is high, and eradication it's really difficult. Especially this would lead to long-term treatments of antibiotics and changing the microbiota with antibiotics, despite there were no reported resistance. When to treat asymptomatic patients? There's a lot of talk about that when we should treat Giardia when it is asymptomatic. Usually they recommend to treat it when there is low prevalence, in the low prevalence country, just in view of potentially reducing of transmission to others. Symptomatic patient definitely does need treatment and duration, and this is treatment definitely would decrease the duration of diarrhea, and when there is an absence of treatment, diarrhea would be prolonged. Treatment modalities, or let's say treatment groups. Quinacarine is the first medication that was used for Giardia, and it has almost 77% success rate in eradication of the cyst, but unfortunately it has a limitation due to compliance to this medication. You could see in the duration of it that it should be used for 7 days, as well as it has toxic side effect in form of toxic psychosis and nausea plus vomiting. Then the second group that was used as a treatment choices was nitromedazole group, and our friend, which is metronidazole, as they use drug in many places as a treatment. But and this medication is most of us definitely use it somehow for some occasions and few diagnoses. But there was a lot of talk about carcinogenic effect of metronidazole. Do we really believe in that? There is no strong data speaking about that. Despite that, it's still used as one of the treatment modality for Giardiasis. But the golden standard treatment modality is tinidazole, and it is single dose, compliant will be easy, probably there was no much side effect, and it can be used either alone or in combination in cases of failure of medical treatments. One thing which is so difficult about Giardia is that maybe if I came across a patient, I should think about it. Do we have something called treatment refractory, treatment failure, resistance to treatments? And this is again a general rule applied in infectious disease. We said when patient is not responding, either resistant or another diagnosis or treatment failure. So treatment, most likely there were no reported of resistance in Giardia because resistance is needed gene identification, it's need to be studied well, cultured, and this is limited in cases of Giardia. So most of failure of treatments was coming from, let's say, reinfection or refractory cases. And when I should, and in sometimes, as I mentioned, it is more of finding another diagnosis, and this is what may called as post-infection IBS in cases of Giardia, due to enteropathy, and definitely what we called sometimes lactose intolerance. Rule of combination therapy, as I mentioned in the previous slide of treatment, combination of nitidazole group plus sometimes barbamycin plus quinine sometimes. Prevention, we could just speak about prevention at the level of personal, children, pet and animal, community and environments, children and infants, hand hygiene, hand hygiene, hand hygiene. We could just seclude them from school until the diarrhea would be subside, disinfect their toys, and just let them wear tight-fit, waterproof pants and nappies, not allowing them to swim, do water activities. Adult hand hygiene, avoid intimacy with all the types until the symptoms resolve totally, avoiding swimming and exclusion from work, environment, disinfectants, and water boilings and sanitization. Then pets and animals, since everyone nowadays love to have cats, dogs, and the animals that we speak yesterday about. So avoid touching animal boobs, especially the boobs with young animals. Don't touch faces after being near to the animals. Hand hygiene again, and when they have diarrhea, try to just isolate them. Environment and surface, disinfection is the major thing, especially for the services as well as the laundries of the infected person, is one of the major things too as a prevention strategies. I find this brochure was very nice, and I think I may share it with everyone since it's called beaver disease, and in hiking places where everyone nowadays is going out. And it's called also backpackers disease. What I like really about this brochure that they speak about how if they need to, let's say someone would go for hiking for a long time, they may just carry little amount of water because of difficulty in carrying a lot of water. So how they should, let's say, sanitize the water for them, boiling, let's say for 1 minute, even if it's reached 100 degrees, then if the water is cloudy, you should again keep it started for another 3 minutes, then reboil it again, then water filters with a specific size, then chemical treatments, bleach, 2 drops with a perfect contact time, halazone 5 tablets, iodine if it is crystals, 2 honest 2 tablets. Anyhow, when I would plan to just go for hike, I would read this more, definitely. Okay, so what about what we drink as houses? I don't know if we all drink from bottled water or we just buy that one, what we call it, the large blue bottle. So is it really well treated? Are we okay? Are we safe? So, and those definitely on every shop that had معالجة بالأوزون, treated with ozone therapy. So is it really working? Are we safe? What we are doing at houses? Definitely my mom and the housemaid is cooking from those things. So what's going on? So ozone acts as an effective disinfectant for both drinking water and wastewater, successfully removing protozoa such as Giardia and Cryptosporidium, and it is necessitate shorter contact time when compared to other disinfection technique. So it's work, alhamdulillah. The other questions were about the new things, fascinated ultraviolets. I have a small ultraviolet machine in my hand, in my house, that I sanitize my nails and instruments and all those stuff. So it does work for the Giardia that I put my nail stuff in, or it doesn't work. So ultraviolet radiation at 10 millijoule per centimeter مربع kills Giardia cyst effectively, whereas trophozoites and insisting parasite can recover from ultraviolet treatment at 100 millijoule per centimeters and 50 respectively. So it induced double-strand DNA breaks for the organism and it killed them, definitely the cyst and parasites, and the trophozoa. In conclusion, Giardia remain classified as one of the neglected tropical diseases. Contaminated water is the primary vector of transmission, and the infection can present as subacute to acute, posing diagnostic challenges in endemic regions. Treatment typically involve nitromethazole class for medications, and hand hygiene and access to safe water sources are essential measures to prevent infection. With that, thank you so much.